Alright, today we're going to go over Fundamentals Exam 1 study guide. We're going to ask questions and you're going to tell me what you think it is. Alright. Can sputum cultures be delegated? Yes, they can be delegated. How do you obtain a sputum culture? Suctioning into a sterile suction trap or having a patient cough and expectorate into a sterile cup. So before getting the sputum culture, what can we not have them do? Use toothpaste or mouthwash. What are we going to do during the sputum culture to obtain the sputum? Take 3 to 4 deep breaths with exhalation, then full inspiration, followed by a forceful cough, getting 5 to 10 milliliters of sputum. Can we delegate peak flow meters? Cannot be delegated initially, can be delegated for a stable client. What does a peak flow meter measure? Peak expiratory flow for patients with asthma or reactive airway disease. If we use a peak flow meter properly, what can we identify? An exacerbation before clinical signs appear. Alright, can we delegate medication administration? No. How many seconds, when using a meter dose inhaler, how many seconds between puffs we have to wait if the same med? 30 to 60 seconds. How about if it's a different med? 2 to 5 minutes. Well, are we going to use bronchodilators or steroids first? Bronchodilators and steroids. What are we going to do after using a steroid with a meter dose inhaler? Rinse our mouth out. What does a nebulizer do? Add moisture to the meds, which helps in loosening secretions. What are catheters? Catheter inserted into thorax to remove air or fluid from the pleural space, prevent air or fluid establishing in the pleural space, or reestablish normal thoracic pressure. So pneumothorax. Okay, you want to keep the system below. Monitor for bubbling. Okay. Can you delegate artificial airways? No. What are the 3 types of artificial airways? Oral airways, unconscious patients only. An ET tube, you may not need a machine, and a tracheostomy. Can you delegate suctioning? Can be delegated to NAP after assessing respiratory status. What are the risk factors of oropharyngeal suctioning using a yonker? Impaired cough or gag reflex, weak respiratory muscles, decreased LOC, assess for hypoxia. Have O2 available. Are we going to suction straight down the throat or cheek pockets? Cheek pockets. What do we need to know about when doing bulb suctioning? Bulb must be fully depressed before putting in the mouth. What are some things we can do to control secretions during suctioning? Increase fluid intake to thin secretions and encourage cough and deep breathing. Tell me about chest physiotherapy. External chest wall manipulation, including vibration, percussion, and postural drainage. Alright, what are we going to use to determine which areas need postural drainage? X-ray. Can we delegate a sensory spirometry? You can delegate it after initial education. What do we use sensory spirometry for? It helps with deep breathing, visual feedback for long, deep breaths. You got to breathe in to raise the platform. Alright, mechanical. What does positive pressure mechanical ventilator do? Inflates lungs. What does negative pressure mechanical ventilator do? Removes air from the patient's chest wall and forces them to inhale. Alright, nasal cannula. How many liters per minute? 1 to 6. At what percentage? 24 to 44%. Venturi mask. How many liters per minute? 4 to 15 liters per minute. At what percentage? 24 to 50%. 100% non-rebreather. How many liters per minute? 10 to 15 liters per minute. At what percentage? 60 to 90%. Simple face mask. How many liters per minute? 6 to 12 liters per minute. At what percentage? 35 to 50%. Partial rebreather. How many liters per minute? 8 to 12 liters per minute. At what percentage? 50 to 70%. Alright, what is ventilator-associated pneumonia? It may be seen as deterioration in patient status after improvement. You have infection, inflammation, must be on O2 for 2 days. Alright, what's gas exchange? Process in which O2 is transported to cells and CO2 is transported from cells. Inspiration, active or passive? It's active. What does surfactant do? Decreases surface tension and keeps alveoli open. What does atelectasis do? Happens when alveoli collapse and can no longer exchange gas. What is asthma? Initially a problem getting air out, but as the air builds up in their lungs, they begin to struggle to pull any more air in. It's oxygenation. The delivery of O2 to the tissues and cells in the body. What is perfusion? The ability of the cardiovascular system to pump oxygenated blood to the tissues and deoxygenated blood to the lungs. What is hypoventilation? Alveolar ventilation decreases and CO2 increases. What are some causes of hypoventilation? Atelectasis, COPD, and asthma. What are the symptoms of hypoventilation? Decreased O2 sat, shallow breathing, coughing, adventitious breath sounds, mental status changes, dysrhythmias, cardiac arrest, convulsions, unconsciousness, and death. What is hyperventilation? CO2 increases in the body, rate and depth of respirations increase. What are some things that can cause hyperventilation? Anxiety, fever, drug overdoses, effing imbalances, and Kussmaul's. What are the symptoms of hyperventilation? Rapid respiration, sighing, breath, inhalation longer than exhalation, deeper respirations, lightheadedness, and tingling. When will we see Kussmaul's in hyperventilation? Severe metabolic acidosis. What is hypoxia? Deficiency of O2 at cellular level. What is hypoxia caused by? Hypovolemia, high altitude, tissues cannot extract O2 from blood, decreased diffusion, poor perfusion, shock, or trauma. What are the symptoms of hypoxia? Apprehensive, restless, inability to concentrate, decreased LOC, dizzy, cannot lie flat, high pulse rate, respiration, depth. When would you see cyanosis with hypoxia? Late stage. Alright, mobility and safety. Alright, what are some of the complications of the respiratory system? Atelectasis, hypostatic pneumonia, and pulmonary embolism. How are you going to deal with atelectasis? Synthespirometer, cough and deep breathing, ambulating. How are we going to deal with hypostatic pneumonia? Turn, cough, deep breathe, hydration. How are we going to deal with pulmonary embolism? Elevate the extremity above the head and compression devices. What are some of the complications that occur in the cardiovascular system because of immobility? Orthostatic hypotension, increased workload of the heart, thrombus formation. What is orthostatic hypotension? 20-point systolic drop or 10-point diastolic drop. How are we going to deal with orthostatic hypotension? Rise slowly and dangle over bed for a little bit. How are we going to deal with increased workload of the heart? Hydration and get them as mobile as possible. How are we going to deal with thrombus formation? Sequential compression devices, TED stockings, foot pumps, and Lovenox. What are some things that happen to the GI system because of immobility? Decreased peristalsis, constipation, decreased appetite. How are we going to deal with constipation? Laxatives, stool softeners, and emenas. How are we going to deal with decreased appetite? Hydrated, eat foods rich in fiber. Alright, what are some of the complications that happen with musculoskeletal system? Muscle loss, weakness, and disuse atrophy, and then disuse osteoporosis. What is disuse atrophy? If you aren't using the muscle, it starts to atrophy, but the muscle that is left wants to contract, so it leads to contractures. How are we going to deal with disuse atrophy? Passive range of motion, never going beyond where the joint wants to go. What is disuse osteoporosis? Immobilization causes bone resorption, which causes increased calcium loss from bones. What is a joint contracture? It's like a foot drop, permanent plantar flexion, so the foot cannot bend. Severe is reversible. What are we going to do to take care of disuse osteoporosis and joint contractures? Up and moving, or at least in a chair, splints, and footboards. What are the complications that occur in the urinary system because of immobility? Urinary stasis, renal calculi, and infection. What is urinary stasis? Urine becomes hard to empty. And then what is renal calculi? Is not flushed out. How are we going to deal with infection? Well hydrated with non-caffeinated beverage and get them as mobile as possible. What are some of the things that occur in the integumentary system because of immobility? Pressure ulcers. How are we going to take care of pressure ulcers? Keep skin clean and dry, braid and scale, and then nutrition. What is friction? Movement of one surface across another surface, like as you pull the patient in the bed. What is shear? Movement of both surfaces like skin against bony prominences. All right. What are some things that may cause seizures? Seizure inducers, lack of sleep, hormones, and stress. So what are we going to do if someone has a history of seizures? We're set up the suction in the patient's room. Why are we going to time the seizure? Tell us how serious it is and if it's been affected by meds they're on. So for safety concerns, how are we going to put the patient in environment when they're having a seizure? Roll them towards us, pad both bed rails, and embed in lowest position. What are we not going to do after the seizure is over? No questions that concern or confuse them after seizures occurred. And then if we need oxygen, how much can we set up without having an order? 2 liters. Can we delegate seizure precautions? Yeah, but the RN must be the first to apply the oxygen. All right. Are we going to say code red or fire over the alarm if we have a fire? Code red. All right, what's horizontal evacuation? Moving patients from one smoke barrier to another. It's the same floor but different area. All right, what does heat do? Vasodilates and increases blood flow to the affected area, promoting delivery of nutrients and removal of waste. What does moist heat do? So it increases muscle and ligament flexibility, it relieves muscle spasms, and it penetrates more deeply than dry but may cause burns. What are some examples of moist heat? Hot compress, steam humidifier, and sitz bath. What is dry heat? Has less risk of burns but increases fluids loss via sweating and causes drying of skin. In terms of safety, how are we going to deal with hot therapy? Monitor them frequently and do not apply it directly to their skin. What type of patient would we be very careful with when using hot therapy? Spinal cord injury patients because they cannot feel it. Can you delegate hot therapy? Yes, unless it must be sterile because it's being applied to a wound. What does cold do? Vasoconstricts, slowing bleeding, and decreasing the release of inflammatory mediators, decreases edema, and lowers the conduction of pain impulses. What does price mean for cold therapy? Protect, rest, and restrict, apply ice, and compress, and elevate. Can we delegate cold therapy? Yes. All right. What are some examples of clear liquids? Water, apple juice, popsicles. What are examples of full liquids? Milk, ice cream, strained soup, cream of wheat, pudding, and pureed veg. What are some examples of pureed foods? Easily swallowed foods like scrambled eggs, mashed potatoes, vegetables, and fruits. What are some examples of a soft diet? Low fiber, easily digestible like pasta, casserole, and tender meat. What are some... do we trust what the patient's telling us that they can eat? No, check the record. Liquid is easier to aspirate. Before we feed somebody with COPD, what are we going to do? Make sure they rest to conserve energy. Why do we have to watch for pocketing when feeding? Aspiration risks. What we may have to do when feeding someone who has dementia. Cueing. Is hypoglycemia or hyperglycemia most dangerous? Hypoglycemia because the brain uses only sugar. All right, after we give glucose to the patient, when do we recheck glucose? 15 to 30 minutes after. What's the normal blood sugar? 70 to 110. What fingers are we going to use to check glucose? Middle 3 fingers on the side to check test. Where are we going to test babies for glucose? Side of the heel. Can we delegate glucose testing? Checking blood sugar can be delegated, but RN must interpret the number. Alright, who are we going to use telemetry on? Patients with AFib, heart failure, pacemakers, atherosclerosis, strokes, angina, surgery, meds, and electrolyte problems. What does telemetry do? It measures the electrical activity of the heart. What's a good way to remember how to put them on? White right, clouds over green glass, black smoke over red fire, and chocolate close to the heart. How often do we need to change the electrodes on telemetry? 1 time a day. What are we going to also do when we take the telemetry leads off? We're going to let telemetry know. Can you delegate telemetry? You can delegate putting the leads on. All right. So for PPE wise, what are we going to do if patient has had an infection past 90 to 100 days? They go on contact precautions. After 5 days, they would go on universal gloving precautions. What are some examples of diseases that would require contact precautions? MRSA, sepsis, and E. coli. What would we use for contact and tear? Why would we need contact and tear? C. diff. What's the big difference between contact and tear and contact? Contact and tear, you're going to wash your hands before entering and leaving the room. All right, what conditions would cause us to use droplet masks? Flu, RSV, and pneumonia. What conditions would cause us to use airborne masks? TB and varicella. Okay. All right, what's the process of donning gloves? Donning PPE. Gown, mask, goggles, glove. What's the process of doffing gloves? Gloves, gown, goggle, mask. All right, how are we going to brush dentures? What's the process? Away from the gums. Removing the top denture first. Okay. How are we going to preserve dignity when doing perinatal care? All right, drape bed in a blanket and a diamond and do everything you can to preserve patient dignity. Face your body at an angle away from them so you aren't looking at their face. Retract and return foreskin. Clean area first. Start with thighs. It can be delegated. All right, what's the order of doing a bed bath? Eyes first to outer, then face, then fingers up arms, neck, axillary, chest, abdomen, legs, feet, perineal area, back of legs, and bottom. This can be delegated. Why don't we place COPD patients on high levels of oxygen for a long time? Takes away their hypoxic drive. All right. Nasotracheal or oropharyngeal sterile? Nasotracheal. What's the suctioning amount for adults? 100 to 150. What about for kids? 100 to 120. And infants? 80 to 100. That's for 1 year or less. What types of patients can we not delegate suctioning to? Patients that had oral or pharyngeal surgeries because of risk of bleeding. Who do we not do range of motion on without an order? Orthopedic trauma or spinal patients. Know about restraints. We know about moving, body mechanics, turn patient every 2 hours. Low Fowler's 30 to 45, semi Fowler's 45 to 60, high Fowler's 60 to 90, Sims is for rectal exams, suppositories, and enemas. Okay. Gait Belts always walk on the patient's strong side and with their weak side towards the wall. Okay. So cane be on the person's strong side. So they'll go cane, then weak first, and then strong. Okay. Okay, got it. TEDs, you need an order for TEDs. Can be delegated. But they're contraindicated with patients with wound swelling, redness, potential DVT. Okay, that's that.